Hello everybody. We are demonstrating phacoemulsification in 8 cases with different grades of cataract without use of viscoelastic. During phacoemulsification, viscoelastic is mainly used during continuous curvilinear capsular axis and while implanting intraocular lens. Its basic benefit is maintenance of anterior chamber, which helps in easy maneuverability. It also helps to enlarge and stabilize pupil. It also helps in hemostasis. All above properties of viscoelastic can be very well fulfilled by continuous irrigation of BSS from side port. Viscoelastic itself has its own problem intraoperatively and postoperatively. Intraoperatively, it can cause post-occlusion surge, which can happen during sculpting if high viscosity OVDs are not removed before. Another problem could be wound burn in hard cataract where fluid space is necessary around phacotip. In our videos, we are performing all steps of phacoemulsification under continuous irrigation. It is a positive pressure surgery, so there is a less chance of post-operative inflammation. Due to positive pressure, there is no chance of ingress of fluid from outside, which avoids possible risk of intraoperative entry of fluid from conjunctival cul-de-sac and thus avoids infection. Viscoelastic related post-occlusion surge and wound burn can be completely avoided. As viscoelastic is not used, its time for injection and its removal can be completely avoided, which saves lot of time. When we use high density viscoelastic, particularly in premium intraocular lenses, removal of this viscoelastic behind intraocular lens is potentially risky procedure at the end of surgery, particularly when pupil is small. This risk can be completely avoided. Less number of entry and less number of exits from anterior chamber makes surgery much more safe. Postoperatively, risk in intraocular pressure rise due to retained viscoelastic and viscoelastic related tasks can be completely avoided. We did pilot study on 56 eyes as a case control study where 28 each cases of phacoemulsification with visco and without viscoelastic are compared with their endothelial count preoperatively and postoperatively, and we could found that there is no statistical significant difference in endothelial damage in a non-visco group. There are other supporting studies which also shows that surgeries done under irrigation does not show any significant endothelial damage. In all our videos, we have edited phacoemulsification part as it is not relevant to our study. But part of doing CCC and intraocular lens implantation is unedited. But it is fastened 3 times to save some time. Basic advantage of doing CCC under irrigation is maintenance of anterior chamber. Irrigating probe act as a second hand to keep CCC flap folded and helps in natural curvilinear shearing force, which is particularly helpful in mature cataract. While implanting intraocular lens, deep anterior chamber makes intraocular lens implantation very easy. Even we can flip that IOL in anterior chamber without damage to endothelium. Irrigating probe again helps us as a second hand in easy tapping of IOL and its rotation that will also avoid step of IOL dialing with the use of dialer. All intraocular lenses can be easily injected under BSS Only those IOLs which requires rotating movement with a second hand cannot be injected under irrigation. Continuous flow of fluid in anterior chamber during intraocular lens implantation helps in bringing peripheral small cortex or epinucleus behind iris in center, particularly in mature cataract. This is a slide which is showing our study.
In a pilot study done at our center, endothelial count studied between Visco and non-Visco group does not show any statistical difference. Now I would like to demonstrate three more Visco-free cases in small incision cataract surgery. In small incision cataract surgeries, we used AC maintainer in first two cases, which was popularized by Blumenthal long ago. As in FECO, CCC and IOL implantation were equally safe and easy in small incision cataract surgery. Nucleus delivery is also safe, except in few cases we may encounter iris prolapse through main wound, which can be managed by reducing bottle height. Visco-free surgery needs to be practiced, then only surgeon can understand its advantages. In this small bucket of surgeries, we would like to give a message that surgery can be safely performed without visco. In ninth case, nucleus was large, it was engaged in wound and later delivered by making two pieces. In ninth case, we have used 23 gauge infusion cannula instead of AC maintainer, which is freely available with vitreoretinal surgeon. We could not find any added advantage over AC maintainer. In this 10th case, as nucleus was large, relaxing incision was given to CCC as CCC was relatively small. In different, in all SICS cases, we would not have thought of doing surgery without visco, but we could do it easily. In different grades of cataract, we have demonstrated relevant steps and surgery in FECO and SICS.
So to conclude, cataract surgery can be safely performed without use of viscoelastic, with added advantage of controlled surgical procedure in deep anterior chamber with positive pressure. Least entry and exit of anterior chamber with continuous flow of fluid reduces fluid ingress and avoids infection. It is time and cost saving. Post-op side effects of visco can be completely avoided. Thank you.